Welcome to another episode of Talking with Docs. I'm Dr. Brad Weening.
And I'm Dr. Paul Zalza.
On today's episode, we're going to be talking about ankle fractures.
Very common. This is a common injury that happens to people of all ages.
So let's start at the beginning, Paul. Someone comes and says, I was told that I have a fracture or a crack or a break. How are they different?
Right. Fracture, crack, break, they're all the same thing, basically. We tend to use the term fracture in orthopedics most commonly, but I guess more common term would be broken. I have a broken ankle. It's all the same thing.
Yeah, and often what varies is the degree of displacement of the two pieces of the bone, and that's probably why words like hairline are used, or crack, or whatever.
Yeah, agree. Yeah, not every fracture is the same, that's for sure, but whether you use the word fracture, crack, or break, the bone is broken.
Okay, when someone says they have a broken ankle, what exactly are we talking about anatomically?
Right. So the ankle joint is made up of the bottom end of the tibia, the bottom end of the fibula, and the talus, which is a bone in the midfoot. So those are the structures that make up the ankle. So when your ankle fractures, most commonly you've broken the fibula, the end of the fibula, and maybe the end of the tibia with it as well, the inside part of the tibia.
Right, so yeah, your fibula is the long skinny bone on the outside part of your leg, and your tibia or your medial malleolus is that little bump on the inside of your ankle. Do you have a model?
Yeah, let me get it.
Okay. Usually this happens either walking when you have a fall, or if you trip, or you fall from a height, or you're playing sports, and those bones are under stress that can't be supported by it, and then it breaks. So here's the model.
Tibia, fibula, and then the talus is in there.
Which is certainly much less commonly broken. We're mostly talking about the fibula and the tibia.
Yeah. So lateral malleolus is the other word for the distal part of the fibula, and medial malleolus is the other word for the end of the tibia that breaks.
So the most common symptoms that people would present with when they break their ankle would be pain, swelling, loss of function or range of motion of your ankle, as well as potentially an inability to weight bear. And those all vary, obviously, on the severity of the injury.
Yes. And if you look at the ankle, sometimes it's red, and sometimes I've even seen them misdiagnosed as infections. Oh, we've got an infection, but it's actually a fracture. So you've gone to the emergency room, you broke your ankle, and then you were referred on to an orthopedic surgeon.
How'd they diagnose it, Paul?
Sure. So the diagnosis is, first you present with those symptoms, then a physician will examine you and push on certain parts around your ankle to see where it hurts, and that will help them determine what kind of x-rays they need to order, but ultimately the diagnosis is made on x-ray.
Okay. And then, so like you said, a physician sees you and then potentially refers you to an orthopedic surgeon that you would either see that day or maybe later on in their clinic?
Yeah. And you don't have to be seen immediately for an ankle fracture, but you're seen, at some point, usually within 1 to 2 weeks.
Right.
So what happens then?
So then they determine the severity of the injury and the treatment options. So I would say the main treatment options for a broken ankle would be either non-operative or operative treatment. Let's talk about non-operative treatment.
Sure. So you've got a fracture of your ankle, probably the lateral malleolus only, so the fibula only, and it's not really shifted or moved a lot, so your treating physician has suggested non-operative treatment, saying it's going to heal okay where it is. You don't need surgery to make it any better. So the mainstay of non-operative treatment for an ankle fracture is some form of immobilization. So we've got to immobilize the ankle to give the bone a chance to heal. If the bone is constantly moving at the fracture site, it won't heal. So a cast or a cast boot is used to immobilize the bones to give them a chance to heal.
Okay, so two main types of casts. Traditionally, plaster was the only choice, and then as time has passed, we've gone into a fiberglass era. The main differences, I would say, being cost. One, plaster is significantly cheaper.
Right.
Fiberglass is significantly stronger and significantly lighter.
Right.
But I think both provide a reasonable way to immobilize an ankle.
And we also have cast boots available. So they look like a big ski boot, and they're they're easy to take off and put on, so you can wash and scratch underneath the cast because those do get itchy.
Yeah.
So a cast boot is also a form of immobilization that's commonly used in non-operative management of ankle fractures.
But in general, you'd say they're probably comparable.
Yeah, I would agree.
And yeah, so it's a dealer's choice decision, partially the surgeon's decision, partially the patient's decision, depending on their financial situation or their benefit situation.
And generally, it's 6 weeks. 6 weeks is sort of the standard time of immobilization. Sometimes it's a few weeks earlier, sometimes it's a few weeks later, but generally you're looking at 6 weeks to give the bone enough time to become strong enough that it no longer needs to be immobilized.
Okay, and then if your fracture is determined to be an operative type of fracture, what's usually involved, Paul?
Okay, so now you've gone to see your orthopedic surgeon and they said, oh look, you've got a fracture that would better be treated by surgery. These type of fractures usually involve some form of displacement or movement, so the fibula is broken but it's shifted way over. Maybe the medial malleolus is broken as well and the ankle's shifted. It's not aligned anatomically, it's not aligned the way it's supposed to be. So the goal of surgery would be to put everything back where it's supposed to be and then hold it there with some sort of fixation, again, to give the bone enough time to heal. And we usually use plates and screws in that setting.
Yeah, so essentially the plates and screws are doing the job of the cast.
Right, but inside. And
Got it.
they're not, they will fail. The plates and screws will fail. The plates will break. The screws will pull out if the bone doesn't heal in the right amount of time. If the bone takes too long to heal, the hardware will likely fail.
Got it. So moving beyond then, so regardless of non-operative or operative treatment, you had mentioned a guideline is approximately 6 weeks. A lot of people ask me, Paul, what's the deal with weight bearing? Can I walk on it? Can I not walk on it? When does that stuff happen?
Yeah, for the majority of fractures, I don't let you walk on it after until things are a little bit stable. So non-operative, both non-operative and operative, generally you're looking at 6 weeks in the cast, non-weight bearing.
Yeah, and some people will let you toe touch weight bear just a little bit for balance because actually it requires a lot of force and coordination to keep your leg off the ground. But yeah, in general, you're trying to protect the bone from moving, like Paul had said before.
Okay, so you've gone now, you've 6 weeks, either you had surgery or you were lucky enough not to require surgery. The cast has come off. Can you start running? Can you start jumping on it?
So usually what I do is, depending on the severity of the fracture, the number of times I see between 0 and 6 weeks would vary. So you might be seen once or twice, or you may go the whole 6 weeks without being seen. But you definitely will get another x-ray at 6 weeks. We would assess on the x-ray whether or not the fracture had healed, and if it had, we confirm that with physical examination that you're not severely sore or that it doesn't look deformed, and then determine at that point. Usually I would let people start walking at 6 weeks, get them involved in a dedicated physiotherapy plan, but certainly not return to normal activities the minute they come out of a cast. That's not realistic.
Right, so you get the cast off, your ankle's going to be stiff, it's going to be atrophied, so the muscles are going to be weak. So physiotherapy to get the range of motion back and the strength back. And I say it's generally another 6 weeks before you're really feeling closer to your normal self.
Especially for adults, would totally agree. Another thing that seems to go is what's called proprioception, or your ability to navigate uneven surfaces or balance. So that really goes away when you're in one of these awkward boots for 6 weeks.
Okay, so you've had 6 weeks of treatment, either you had surgery or not surgery, you were in a cast, you got the cast off, you've done 6 weeks of physiotherapy. What are some of the long-term outcomes now that I can expect after my ankle fracture?
So what I tell all of my fractures is that your limb, whatever you broke, is never going to be 100% normal. Normal, perfect, 100% are usually terms I don't use. That certainly is our goal. But often there is some component of the injury that's irreversible. It is very variable depending on the location and the severity of the fracture, but you may have some impairments with respect to terminal range of motion, strength, or potentially endurance, as well as potentially some background levels of pain.
Right, I agree.
But very variable.
And I tell people, whenever you break a bone at or near a joint, you're at risk for getting post-traumatic osteoarthritis after.
Wonderful.
So that is basically, it means everything you said. Pain, stiffness, not back to 100%. That's largely because when you break a bone at or near a joint, you've damaged the cartilage that's inside the joint. And in adults, cartilage inside the joint does not have the potential to heal or regenerate. So some damage is done in the joint that you can't see on x-ray. You may develop varying degrees of post-traumatic osteoarthritis. So I'll tell people like, oh, 20 years down or 10 years down the road, your right ankle hurts, but your left ankle doesn't. You're like, why is my right ankle hurting? Oh yeah, I broke it 10 years ago when I tried my son's skateboard, for example.
Got it.
Okay.
What about work?
Work, yeah, that is variable.
Very.
When to go back to work is variable. It depends on a lot of factors. The severity of the injury, for one, the type of work you do, for two, and whether or not you have disability benefits of some sort that can pay you while you're recovering. People who are self-employed often have to just get back to work earlier anyway so they can make an income. So that is variable, but generally for a type of job where you got to do some walking around and standing, I would say at least 3 months.
Yeah, and I think that's reasonable because A, the non-weight bearing potential could cause a significant problem at your work, as well as driving. I think there's some pretty good studies that have shown about 9 weeks after a fracture is when your ability to react quickly enough to hit the brakes is a guideline. So often you can't even drive for 9 weeks if it's your right foot. So yeah, I tell people 3 months is a reasonable goal.
Okay, and then there's one other complication of fractures of the lower extremity, including ankles, that you have to be aware of, and that is the risk of developing a blood clot, or a DVT, which is a deep vein thrombosis. Itself, it's not a big deal if the clot stays in the lower leg, but if a piece breaks off and goes to your lungs, it can be fatal. That's called a pulmonary embolism. It's very rare, but it can occur. So whenever you're immobilized because of a lower extremity fracture, you have to be very aware of whether or not you're developing calf pain. If you have a lot of calf pain and tenderness, you should go get that checked out right away. And usually you'll get an ultrasound or some imaging done to see if you have a blood clot in your leg, if it's developed because of the fracture and the immobilization. And then you may require treatment for that.
Yeah, similarly, if you develop the chest pain or shortness of breath related
Yes.
to the pulmonary embolism, straight to the ER. And different surgeons have different strategies as far as how much weight you're allowed to put on it, whether they would consider aspirin or something a more aggressive anticoagulation. That should be discussed with your doctor based on all of the rest of your other health risk factors.
Yeah, for sure. If you have, if you've had a risk of blood clot, people at increased risk for blood clots include people who've had them before, people who are on the oral contraceptive pill, if you have a cancer going on, or some sort of immobilization, extended immobilization. Those are people who are at risk, increased risk for a blood clot, and you may need some sort of medicine to help prevent a blood clot.
All right.
That sums up ankle fractures. If you have any other questions.
About ankle fractures or any other type of orthopedic problem, please feel free to email them to talkingwithdocs@gmail.com. We'd be happy to answer them.
And remember, you are in charge of your own health.
See you next time.